Good afternoon, everybody. Just waiting just a minute until everyone's in the room. And yes, it is 12 o'clock or noon in my time zone. So good afternoon, everyone. My name is Anita Go, and I'm a Principal Research Fellow and the Director of Social Gerontology at the National Ageing Research Institute. Welcome to our online Seminars in Ageing program. I begin by acknowledging the traditional owners of the land on which each of us are meeting today, wherever you are. And for me, that is the lands of the Wurundjeri Woiwurrung people. I would like to acknowledge the traditional owners of the lands and the waters and the skies across Australia. I pay my respects to the elders past and present and to all Aboriginal and Torres Strait Islander people, including members of the Stolen Generations. Regarding the meeting platform, MS Teams, at the conclusion of the talks, we will have some time for question and answer. If you have any questions, you can submit them throughout the seminar using the Q&A function, which can be opened using the Q&A tab at the top of your screen. So it looks like two speech bubbles, and one of them has a question mark in it. So we have switched off the chat function, so you won't be able to use that. You are by default muted and your camera turned off. But if you prefer doing the Q&A, you can use the raise your hand function, and we will work in the background to unmute you and turn the camera on, and you can do that yourself too. Today's seminar will be recorded and uploaded to our website and YouTube channel within a few days, so please keep in mind if you do turn on your audio and video to ask a question, you will be included in this recording. Great. So I take great pleasure in introducing this particular session, and it features research project updates from some very talented early career researchers at the National Ageing Research Institute. So today we'll be hearing from Dr Ellen Gaffy, Kayla Locke and Lysha Lee. But first, cab off the rank is Dr Ellen Gaffy, who is a research fellow at NARI and graduated with her PhD from La Trobe University. At NARI, Ellen has worked on many projects across a range of research areas, including dementia, mental health, carer support, and elder abuse. Her PhD research explored the involvement of people living with dementia in co-design. She's experienced working with people living with dementia and family carers across both community and residential care settings, and is has particular expertise in participatory research methods and improving active consumer and community involvement in research. So over to you, Ellen, and thank you.
Thanks, Anita, and good afternoon, everyone. Today I will be presenting some preliminary findings from data that we've been collecting from family members of residential aged care residents as part of the Improving Palliative Care in Residential Aged Care Using Telehealth project, or IMPART for short. So drawing on this data, my presentation today will explore family members' experiences of their relatives' end-of-life care. So to begin with, I will just provide you with a very brief overview of the larger IMPART study and what the IMPART study is aiming to do. So IMPART is a large NHMRC funded trial that is designed to improve end-of-life care that's provided in residential aged care by delivering a needs-based end-of-life education and clinical support intervention for residential aged care staff. So the trial is assessing the effectiveness of the IMPART intervention on enabling preference-based care, reducing unplanned hospitalizations, and improving end-of-life care quality. Quality end-of-life care is essential for residents in aged care to ensure comfort and dignity at the end of life, and also to reduce unplanned or unnecessary hospital transfers when appropriate care may be provided within the residential aged care facility itself. So the IMPART intervention consists of interactive end-of-life care education for nurses, clinical care coordinators and GPs who are working in residential aged care homes, and it also provides support from specialist hospital in-reach teams using telehealth. So we have a very large team working across IMPART, and the team is led by the CI team listed here. And the study is being run across a number of locations, including NARI, the University of Melbourne, the Royal Melbourne Hospital, Northern Health and Austin Health. This is a 3.5-year study which began in 2022, and the active intervention just very recently concluded at the end of October. The primary question that the larger IMPART study is aiming to answer is whether the IMPART intervention reduces unplanned hospital admissions of residential aged care residents over the trial period. And for that, we will be looking at hospital admissions data, but we also have a number of secondary research questions that we will be exploring also. And family members are key sources of information on end-of-life care quality and are contributing important data for evaluating IMPART. And that is what I'll be sharing with you in the rest of my presentation today. So family members of residents who died at the 10 participating aged care homes during the trial period were invited to take part in a telephone survey about their relatives' end-of-life care. And the survey included 3 key tools. Firstly, the satisfaction with care at the end-of-life scale, which assesses family members' satisfaction with the care that their relative received. Secondly, the comfort assessment in dying scale, which measures comfort and end-of-life symptoms. And thirdly, the IceCap close person measure, which captures the impact of end-of-life care on family members. These were all Likert scale tools, so participants also had the opportunity to provide responses to some open-ended questions, which offered an opportunity for them to share some more detailed responses about their experiences. We analysed the quantitative data using descriptive statistics, and the qualitative data were explored using thematic analysis. So as I mentioned, the active intervention just very recently finished at the end of October. So we are still collecting and finalising data collection for that final month. So the data that I'll be presenting and discussing today is preliminary data that has been collected up until the end of June this year. And at that point, we had 34 respondents to the survey. Most respondents were adult children of the resident who had died. Most residents died at the residential aged care home they were living at, and the mean age at death was 90 years. So on this slide here are the results from the satisfaction with care at end of life scale. So this one explored family members' views of the care that their relatives received. Respondents answered on a strongly agree to strongly disagree scale. Overall, the responses were mostly positive. Nearly all respondents agreed that the healthcare team was sensitive to their needs and feelings, with 97% of participants either strongly agreeing or responding or agreeing to that item, and 94% of participants felt fully involved in the decision-making about their relatives' care. The survey did also highlight some areas for improvement. Around 18% of respondents felt that their family member did need better medical care at the end of their life, and 21% of participants reported that they didn't always know which doctor or nurse was in charge of their family member's care. After each measure, we asked the participants if they would like to add any further detail about the questions they had just answered. So in terms of satisfaction with care, family members really highlighted and spoke very positively about the compassionate care and comfort that was provided to them by the residential aged care staff. This was particularly around respecting the dignity of the resident who had died, and also that some staff sometimes acted as advocates or additional support for them, for example, pushing for a GP review. Families did, however, note differences between the regular or weekday staff and the weekend or agency or casual staff, in that they felt that the regular staff knew the resident better and on a more personal level. And because of this, they felt that they were more across their condition and where things were at generally. They also noted that the tone set by the manager of a residential aged care home is really important, because they noticed that that then filtered down into the staff. This is a quote by a participant speaking about the process of making the decision of where her father would die. And she spoke because he had been in and out of hospital quite frequently, and this process of moving in and out of hospital was really difficult for him. So ultimately, the preferred place of death for him was decided to be the aged care home, and this was supported and facilitated by the different care teams involved. So she said it was just really difficult for him to go into hospital and be in the ambulance for such a long time. So they came up with a plan for the end of life, which could be managed at the facility, and it was really good, because there was a lot of input and discussions and a plan, and his dignity and all that was looked after. So everybody sort of agreed that he wasn't going to get the same care with plans in place, and everything was organised on that day. Additionally, some areas for improvement were also highlighted, particularly around communication at the end of life and how this impacted on satisfaction with care. A lot of family members spoke about wanting to be better prepared and to know what to expect from the end-of-life care that their family member was receiving. And this was around what dying might look like, about what decisions they might need to make, what options and interventions were available to them. And some people reported that they didn't feel that they received this. There were also some concerns about the communication between different care teams involved in their family members' care. For example, between aged care staff and GPs or geriatricians, with families describing care between the different teams as sometimes feeling disconnected or disjointed, or feeling like they had to chase staff for updates, or feeling responsible for holding all of that information about their family member. Other participants also felt unaware of the relative's decline, or the urgency of their condition wasn't communicated to them, and in some cases meant that they weren't present at the time of death. However, family members did also acknowledge that this can be challenging for aged care staff to know and be able to communicate in time. So this next slide presents the findings from the Comfort Assessment in Dying scale, which measures comfort in the last week of life. So the most frequent symptoms that family members reported were shortness of breath, which was reported by 38% of family members, followed by discomfort and restlessness, and also pain, which was reported by 29% of family members. So these findings highlight that while many residents were comfortable overall, symptom management and communication about these symptoms to family members remains a key focus, and this was highlighted further in some of the open-ended responses. So one family member described how her dad's pain was measured using a FACES pain scale, and she talked about how the staff explained that to her. Another participant reflected frustration about medication guidelines, feeling that the limits didn't always match her mum's needs. Others felt that sometimes they had to prompt for or request stronger pain relief, but also reflected that perhaps they didn't know or hadn't been told what the medication protocols were, and maybe this was something that wasn't able to be done. So the final tool was the ICE-CAP measure, and this captures the impact of end-of-life care on the family members. there were mostly positive responses to this measure, with the most variability in the responses to the item about communication. Family members described some of the emotional and practical realities families face when a relative dies in aged care. Some described a sense of shock and feeling unprepared, even when they knew their relative was declining. Others spoke about the logistical pressures that follow a death, such as having to clear a room soon after, which can add to their distress. At the same time, families also recognised the positive aspects of care, particularly when their loved one was able to die peacefully within the aged care home, avoiding an unnecessary transfer into hospital and maintaining their dignity at the end of their life. So then, to sum up, family member perspectives offer valuable insights into what quality end-of-life care looks like for both residents who die in aged care and their families. Their experience highlight both the strengths of current practice and important areas for improvement. And these findings can inform improvements in end-of-life care planning and also in staff professional development, education and targeted training, which can enhance responsive and person-centred end-of-life care in residential aged care homes. So then just to finish, I would like to thank the 10 residential aged care homes who are involved in this project and all of the staff and residents at those homes. I would also like to thank the Melbourne Ageing Research Collaboration for their support of this project, and also a thank you to all of the staff and researchers working on this project across the IMPART Working Group and Steering Committee. So thank you.
Thank you, Dr. Gaffy, and also for kind of presenting really important work that bereaved family members' voices can help us understand what matters most, like compassion and communication and really honouring the personhood of people in their final days. So thank you, Ellen. Next up, we are hearing from Lysha Lee. Lysha is a PhD candidate in Applied Health Services in Ageing and Aged Care, supported by a joint scholarship from Deakin University and NARI. She holds an honours degree in psychology and brings a multidisciplinary lens to her work with research interests spanning aged care, mental health across the lifespan, social health and community building. Lysha's doctoral research adopts a realist approach to evaluate how intergenerational programs can enhance the psychological health of older adults and the experiences of staff in residential aged care settings. Lysha actively contributes to collaborative research initiatives, including the evaluation of the Positive Ageing Digital Storytelling Intergenerational Program at Swinburne University. Thanks, Lysha, over to you.
Thank you, Anita, and thank you for this opportunity to present some of the work for my PhD project. I will share my slides, make sure that's looking good. Awesome, thank you. All right, so as mentioned, I will be sharing some of the work done for my PhD work on intergenerational programs in residential aged care settings, and an acknowledgement to my supervisory team as well for their support on this work.
Thank you, Lysha. That was really interesting and a great kind of overview about how complex intergenerational programs are, but that they can succeed when the right mechanisms align with the right contexts. And using that realist approach is also really interesting to help design the right programs that are adaptable, inclusive, and meaningful for all of the people participating. So thank you. That was great. I will now hand over to Kayla Locke, but let me introduce you first, Kayla. Kayla is a research officer at the National Ageing Research Institute. She's worked on several projects at NARI and also as part of the Melbourne Ageing Research Collaboration, or MARC as we like to call it. Kayla has supported lots of research projects covering lots of diverse topics like end-of-life care, mental health, dementia and ageism. Kayla is a PhD student with the University of Melbourne, evaluating components of the NHMSC-funded IMPART project that you heard about from Ellen before. And Kayla has also previously worked in the community sector, coordinating social support programs for older people and people living with a terminal illness from a migrant background. So thank you, Kayla, and over to you.
Okay, I'll just get my slides and my notes. Okay, thank you so much, Anita. So today I will be presenting preliminary findings from my primary PhD project, which is a realist process evaluation of NARI's IMPART trial to understand how and in what circumstances implementation of palliative care interventions in residential aged care work. And the advantage I have in presenting today is Ellen's already introduced you to IMPART, and Lysha has already provided a great explanation of the realist approach. So I'll try to skip over and avoid repetition where possible. Just to recap, so in Australia, we know residential aged care facilities are the second most common place of death after hospitals. However, the quality of end-of-life care is often reported as suboptimal. And we've seen this in the Royal Commission into Aged Care and reports by Palliative Care Australia, who have argued that palliative care services in residential aged care are underfunded and underserviced. So residents are more likely to present to hospital emergency departments than older people living in the community, and these admissions can often result in the resident dying in hospital when appropriate care could have been provided out of the facility with the necessary supports in place. So telehealth has been touted to have the potential to improve access and clinical outcomes and reduce cost of service delivery. However, further research is needed to evaluate telehealth and go beyond merely describing its potential benefits. So as Ellen covered before, NARI developed the IMPART program, which aims to reduce avoidable hospitalisation at the end of life by engaging specialist support provided via telehealth and tailored staff education. And I am going to present today from the first 3 waves of the trial, so 6 facilities out of the total 10, as we're still finalising data collection and analysis for the final 2 waves. And I might skip on to what the program actually involves and looks like. So over a 6-month active intervention period, 5 components were rolled out at each, as shown on the timeline here. So the first, the facility was asked to establish a planning ahead team of approximately 2 to 4 staff, and whose role it was to champion the program. And GPs who regularly attend the participating facilities were also asked to participate. And next, the planning ahead team undertook a local needs analysis to identify areas for improvement in end-of-life care. And then in month 2, the research team facilitated a workshop to present findings from the local needs analysis and co-design an action plan to tailor the intervention to the facility's needs. For the 4th component, facility staff were given access to an online training package and a 90-minute goals of care online training session provided by aged care specialists. And finally, the residential in-reach teams were engaged as facilitators to foster rapid communication via telehealth and to support the planning ahead teams to achieve the goals set out in the action plan. So why I have chosen a realist approach for this process evaluation, many complex interventions targeting residential aged care have demonstrated potential to reduce unplanned hospitalisation. However, there is little evidence to explain how and in what circumstances these palliative care interventions can be successfully implemented to bring about the desired change. And without this information, we are unable to reproduce the results and inform national strategies. So the realist approach, as Lysha described, focuses not just on outcomes, but on contextual factors and mechanisms of change to develop an explanatory account using this formula of context plus mechanism equals outcome. For this realist process evaluation, each facility was evaluated as a case study with the aim to identify and explore the patterns of context and mechanisms that facilitate or hinder the successful implementation of IMPART. And if you'd like to know more about the methodology, the protocol for the realist process evaluation has recently been published in JMIR research protocols. So on this slide are the data sources and how they correspond to the rollout of the active intervention. So facilities completed an information form at the start of each wave. I completed non-participant observation of the IMPART workshops to observe the action planning process. Then at the end of the active period, activity logs and the final action plans were collected, and online training completion data were extracted. Descriptive statistics were generated from the quantitative data, while the action plans were analysed thematically. I also conducted semi-structured interviews at 3 time points. First, following the action planning workshop, at the end of the active period, and 3 months post-intervention. The interviews explored participant motivation, barriers and enablers to implementation outcomes, and hypothesized mechanisms of change. 45 interviews were conducted, 32 with planning ahead team members and 13 with InReach. And the interview transcripts were reviewed for context mechanism outcome configurations using a coding framework. So today I will discuss 2 central mechanisms of change that we've identified so far, using the realist understanding of a mechanism being the hidden causal links between intervention components and outcomes. So first, the perceived and actual fit of IMPART depended on participants' ability to differentiate the program from current ways of working. So this was hindered by inconsistencies in policies guiding the documentation of care preferences and the availability of policies around telehealth use for palliative care. Some interviewees did not see an increase in their current use of telehealth to offer a relative advantage, citing preferences for in-person consultation for palliative care, which was supported by the close physical proximity of the InReach teams to the facilities in Melbourne. Insufficient IT infrastructure was also a barrier that was reported by several participants. These factors contributed to a lack of readiness and clarity about the desired practice change IMPART required, and consequently a demotivation to take steps towards the adoption of increased telehealth use. However, it should be noted that coinciding with the rollout of IMPART was the expansion of the Victorian Virtual Emergency Department, which many participants reported increasingly adopting into practice, particularly for rapid access to specialists during after hours. And this is a quote from one of our InReach participants highlighting their uncertainty about the perceived advantage to increasing telehealth use for palliative care with that particular facility. So they said, in the nursing home building, their Wi-Fi connection and their access to a tablet device is not great. And often what ends up happening is either we give them a phone call or we go and visit in person. Because their location is relatively close to us, the response time is going to be the same, if not better. Alternatively, at facilities that had a stable cohort of regular staff and were able to select champions to the planning ahead team based on their motivation to provide quality palliative care, the needs analysis and action planning components of IMPART were received positively. The planning ahead team members felt validated during this process and were able to reach consensus within their teams as well as shared commitments with InReach, who appreciated the opportunity to hear the facility staff reflect on and evaluate their practice. So by tailoring the intervention through the action plan, goal attainment then led to a sense of pride in facility staff and increased motivation, allowing IMPART to fulfill a need. The goals identified in the action plans mostly related to improving the documentation of goals of care and resident care preferences, followed by the availability of bereavement support and resources for both family and staff. And this is a quote from a facility planning ahead team member reflecting on the action planning workshop. They said, "I thought it was great how we were afforded the time to bring up questions and concerns that we had. That first meeting wasn't just about being told what we need to hear. It really allowed us to put forward some of the concerns we already had. We felt very validated." So moving on to the second mechanism, achieving successful implementation and adoption required adaptations to IMPART for a better fit with the facility workflow. This table shows a task that was set out in the protocols provided and whether facilities were able to carry the task out as intended. So all 6 facilities were able to establish their planning ahead teams, complete the needs analysis and action planning component, and schedule and attend the online goals of care workshop. GP participation in formal intervention activities was only recorded at 1 site. And in the activity logs, it appeared as though regular formal project meetings were not held. So just 2 sites reported having the monthly meeting with InReach via the phone or video call, and no sites reported having the internal fortnightly planning ahead team meetings. However, from the interviews, it became clear that adaptations were made to establish communication channels that were more suited to the residential aged care context. So at facilities where high levels of fidelity were achieved, strong, supportive and engaged mid-level leaders were present who were keen to share ownership with staff interested in planning and palliative care. At these facilities, the InReach facilitators also initiated the scheduling of meetings and visits rather than waiting on the facility to reach out. This allowed for participation in part to be legitimised and action taken towards successful implementation. As facility staff work across various shifts and are not desk-bound, alternate communication channels rather than formal meetings were essential to share the workload of participation and monitor progress. The planning ahead team membership was very significant to generating enthusiasm for IMPART and relied on an existing level of teamwork. One facility invited 2 personal care assistants to participate who were very eager to develop and share their knowledge among other carers through informal chats at breaks and handovers. And they valued the opportunity to discuss palliative care with senior staff as well. At another facility where all staff were nurses, 2 enrolled nurses led implementation, which they managed through a group phone chat. They delegated tasks to other staff, leading to a whole of facility approach and high level of interest in tracking progress towards goal attainment. Just lastly, adaptations were also made to improve the uptake of the online training module content. So quantitative data on online training engagement appeared quite low. 72 participants were provided access, but just 13 people were recorded as having completed the modules. And there were some recurring barriers reported by participants, including its accessibility. Individual links had to be arranged by the research team and sent via email, and the self-directed format did not suit staff where protected time was not provided. And planning ahead team members also highlighted that facility staff are inundated with training and compliance requirements, which has led to a training fatigue. However, planning ahead team members that were responsible for leading regular toolbox sessions or short small group sessions aimed to develop staff skills and knowledge, integrated the module content to these existing opportunities, and these members reported good results due to the increased relevance for staff, whereby they were able to discuss the content and make connections to existing practices with their co-workers. So early findings from this realist process evaluation highlight both the potential and challenges of implementing the IMPART intervention. The program has shown promise through embedded reflection and evaluation components that support facility staff to tailor the intervention to their needs and strengthen collaboration with palliative specialists. However, variability in training engagement and the need for workflow integration underscore areas for improvement. We know that training alone doesn't lead to practice change. Flexibility in implementation and adaptability in palliative care intervention design are key to success in residential aged care. to ensure staff have access to valuable professional development opportunities to develop their confidence and skills to provide quality palliative care so that residents have access to the high quality care they should expect. I just finished by also thanking all the residential aged care and InReach staff who participated in this study, as well as the IMPART working and steering groups and Melbourne Ageing Research Collaboration who have facilitated this project. Thanks.
Thank you, Kayla, for sharing your important findings. And really what stands out is telehealth in palliative care isn't just about technology, it's about other things like relationships, trust and adaptation. And the realist lens again, and like Lysha reminds us, just to look at success and the why and how of interventions and not just whether they work. So thank you for presenting that. We now have some time for question and answers. Again, if you have any questions, submit them through the Q&A button up the top or raise your hands and ask it in person, noting that you will be included in the seminar recording if you do this. You can also upvote and give thumbs up and other reactions to questions in the Q&A. And just remember that the chat function is turned off if you do want to do that. So, any questions from the audience today? So, not so far, but really thank you to all of our presenters, so Ellen, Lysha and Kayla. I think this was all very rich and thought-provoking insights and highlighted 3 critical aspects of care in residential aged care. And obviously highlighted the talent and breadth of our dedicated early and career researchers in ageing and aged care. So the future is very bright. And I just wanted, I guess, to talk to you about the common theme, if I can try and find one between the 3 presentations. Is it kind of about, you know, systems and interventions, which we all love at researchers, but kind of the additional things above and beyond the systems and interventions. So do you have a comment about how kind of the personhood and the person-centeredness and the topics that you all talked about the context, how that applies to your particular project? So if no one has any particular comments about that, that's fine. It's also just a food for thought kind of thing as well, in that we design interventions, but often it's not enough to just design the intervention. You need to think about the people factors and the setting factors and the regulation factors and the environmental factors as well. And I think Ellen and Lysha and Kayla, you're doing that in introspection and investigation in all different ways, but again, really important to understand the intricacies of intervention implementation, I think. So thank you for sharing with us what you're doing in this space. So please join me in thanking Ellen, Lysha and Kayla with your clap reactions, please. They've all done a great job. And please join us next month for the final seminar of 2025, which is on Tuesday, December 9th from 12 o'clock till 1 p.m. The registration links will be circulated shortly as per usual. And again, thank you so much for attending our Seminars in Aging series, and have a good afternoon wherever you are in the world. Take care, everyone.